So this is installment. So this is installment two of the very well critically acclaimed session on communication. Sir doesn't require any specific introduction now, as we had already had an elaborate introduction to Sir last time. Sir, we won't spend more time on the niceties. Over to you and over to the session, sir. Thank you so much.
Thank you, Sri Priya. Thank you, Dr. Deepak. So without much ado, let us start. We have a lot. Welcome to delegates who have joined for today's session, part 2 on communication skills. So let me share.
Sir, just for your information, sir, we
Yes.
can't hear you or see your slides yet.
I'm just trying to get the document.
All right, sir. All right, sure, sir.
Can you hear? Can you see this? Can you
Yes,
see?
sir. We can see it, sir.
Okay, right. So as said previously, today we are going to talk about advanced communication procedures. I call them procedures because just like any procedure, there is an indication for doing these things. There is a usual standard operating procedure, and there is an expected outcome for this. That's why I call them communication procedures, because as medical professionals, we are familiar with procedures. So today we'll be talking about communicating bad news. We'll talk about some models and the reason why bad news should be communicated at all. Then from there, we'll take a diversion to another topic, which is collusion. And we'll talk about that. And once we have done with that, we will come back to communicating bad news. And this time, we will talk about how to go about doing it. We will have a small role play uh, as part of it. And then later on, we will also talk about how to deal with anger in our day-to-day clinical practice. So telling the truth is essentially what bad news is all about. So when you tell a bad news, it is essentially a news that uh, negatively alters our perception of our future becomes a bad news. I'll repeat that. Any news that negatively alters our perception of our future becomes a bad news. We don't know what our future is, but at least we have a perception of what our future will be. So anything that alters negatively that perception becomes a bad. Telling truth has never been easy. It has never been easy. That's why the philosophers of past have also said, Plato has said, there is no one more hated than the one who speaks the truth. It stands true today also. Unfortunately, in the medical profession, we have to tell the truth, and that is why this is such a difficult topic. And in my terminology, I've stopped using the word, rather use communicating bad news or telling the truth rather than breaking, because breaking implies kind of an aggression in that. So this is definitely not an aggressive interacting with a person. It is a gentle, very sensitive interaction. That's why I prefer to call it communicating bad news rather than breaking bad news. So in our settings, usually when a patient comes with the family and we have some bad news to convey, we usually tell the patient go out and we talk to the family. That means we are not disclosing the news, bad news, to the patient. And this practice is called non-disclosure model. This is practiced in many countries, not just our country, many of the Asian countries, many of the Oriental cultures, where it is considered taboo talking about bad news to the person. Therefore, in our practice, we usually tell it to the family. But there are, problems with it, because if what if that person wanted to know? So this gets into conflict with the patient's right to know. So if a patient wants to know, denying that information becomes a conflict with the principles has the right to know. So this non-disclosure model gets into conflict with the patient's right to know. In some countries, you have to convey the news to the patient, the bad news to the patient, and not to the family, because that is how the system is over there, and you are legally bound to do so. In case you tell this to the family without telling the patient can sue you and take you to the court. So in those countries and those cultures, the patient is told, hence it's called a full disclosure model, and you can talk to the family only with the permission of the patient. In these countries or this kind of want to know, and that is the conflict, because the patient has the right not to know as well. So these two models, that is non-disclosure model, gets into conflict with the patient's right to know, and full disclosure model gets into conflict with the patient's right not to know. This happens because in both these models, it is not the patient who decides whether he or she wants to know or not. It is we who decides whether we want to tell the patient or not. Therefore, it is important to create another model which caters to the individual needs of the person, and therefore we'll call it an individualized disclosure model. Basically, there are two things involved. First of all, we need to figure out whether the patient wants to know or not, and the second thing is we have to figure out, if the patient wants to know, how much quantity of information this patient wants, and we give only that much, not less, not more, only as much as the patient wants to know. So this is the individualized disclosure model that we will learn today. But before going there, we need to first understand, why should we communicate bad news at all? I'll present to you three primary points. First thing is, it gives us time to finish off things that we want to finish. For example, if there is a financial things to be settled, or some instructions that we want to give to the family, or if we have a bucket list, for example, there are things that we wanted to do, to enjoy, to go to some place and see things, to eat certain things, etc., etc. So these kind of things will happen only if we understand that our time is limited. Most of the time what happens is we have relationship issues. For example, we may have had a friction with a friend and we haven't spoken to that person in 20 years, and if we knew that our time was limited, we may want to reach out to that person, mend the relationship, ask for forgiveness, give forgiveness, in overall enrich our relationships. But none of this will happen if nobody tells us. And unfortunately, the fact is that less than 10% of the patient population, or rather less than 10% of the population, dies suddenly. For example, in a car accident or a sudden cardiac arrest and things like that. Majority of the people die slowly, either with debilities of age or incurable progressive medical conditions. So actually, for most people, there is this option of knowing whether they are, they have an incurable disease and it is progressing and the time is limited. And who should be telling this? This is primarily the duty of the medical professionals. Unfortunately, we have not been told how to do this, and therefore we are not very comfortable doing this. And in any case, telling the truth has never been easy. And because we are not trained to do this, we would rather not do it. And therefore, we are depriving our patients this precious thing about able to finish many things that they can before they die. And many a times you need some little bit of physical health, and mental ability to finish things. So the early on we let them know, the better for them. Of course, when we tell them, there will be sadness, there will be denial, there will be bargaining, there will be anger, but eventually they settle down. And once that happens, then they think, okay, I have limited time. Then now what is important to me? What are the things that I need to do? So that is the first point, closure of life's business. The second important point is hospital hopping and doctor shopping. What happens is the patient does not know what is the situation. You may have told the family. So your expectation and the family's expectations are realistic. But since the patient does not know the reality, the patient's expectation would be unrealistic. From the patient's point of view, they are very normal expectation. But from our point of view, they are unreachable expectation because it is not grounded in reality. And whenever there is a mismatch between expectation and reality, there will be dissatisfaction. The patient may say, okay, this is a great hospital, great doctors, everything is good, but I am not getting better. And soon that person will be disillusioned with you and will demand that he be taken to some other place. And the family will be forced to take this person to another place. And what will happen at the new place? The patient's hope will rise, and patient will expect that things will be different over here. And initially the person will be very very you know very positive, energetic, hopeful. But eventually in the new place also, the person realizes that what he wants, what he or she wants, that is not happening. Again the person will blame the hospital, the new doctors and everything, and will demand, ask the family members to take him or her to another place. And this goes on and on, you know, hopping from hospital to hospital, going and meeting different doctors, and basically just being miserable, going around all over the place looking for a cure that does not exist. And look at what happens to the family. The family is, forced to be with the patient. They can't go to work, they can't earn. And when you're away from home, even a glass of water or a bottle of water, you have to pay for it. So there is no income, only expenditure. Very soon the family is pushed into poverty. They have to sell their assets. Sometimes they have to sell off their house, and then they have to shift into a rented smaller accommodation, and so on and so forth. A lot of poverty happens in our country due to medical expenses. And therefore, this futile exercise of going from place to place looking for treatment that does not exist, it can be prevented only if the truth were to be told. And who should be telling this? It is our responsibility, but we don't do it. Another important thing that we need to consider is the barriers in relationship this brings about. For example, the patient does not know, the family knows. So if the patient uh, you know is trying to figure out what is going on, the family is trying to hide what is going on, and as a result the family puts on a mask of normality in front of the patient and acts, plays a drama as if everything is normal. Sometimes when the family members are overwhelmed with emotion, they when their eyes wells up, they run away from that place, go to the father's room, go to the bathroom and cry, and then they wash their face and come back and again resume the drama. If they live in a small house, they may run off to the neighbor's house, and the rich person or poor person, they all come, and oftentimes they will come into your office, and then they will cry in front of you. They can't cry in front of the patient because they are just indulging in a drama. They're just trying to put up a brave face. Now, if that tragedy of the family members is bad enough, but what happens to the patient? The patient's body is telling him or her that things are not getting better. The body doesn't lie. The body tells exactly what is going on. The patient may not know exactly what is the disease, what is the stage, and things like that. But the patient know they are not telling the truth to me. Patient understands that, and it becomes very. The patient becomes frustrated, irritated, angry at the family members. Along with it, you will see relatives coming from far off places to come and see this patient, and they stand at the patient's door and look at this patient with a lot of sympathy, and this angers the patient even more. He shouts at the family members, why are these people in my house? Tell them to go away. And the family members just have to stand there helplessly, not knowing what to do. And the patient can hear all these people in the other room whispering, and he or she knows that they are talking about me, but they will never talk to me. So there is this invisible barrier that the patient is all alone on one side and rest of the world is on the other side. So this is basically like being put in a prison for lifetime imprisonment on solitary confinement, except that the walls are made of glass, an invisible glass. You can move through it, but nobody's actually on your side. So all of these are very, very painful experiences, and a lot of negative energy builds up in the house. And many a times family members start accusing each other. The patient gets angry and starts accusing the family members that they are trying to poison him, kill him, they're after his property. A lot of harsh words come about in this phase, and the family really don't know what to do. And finally, when the patient dies, they look at his or her portrait, a picture with a garland on it, and wishing only if they had some more time to spend with this person. But the question is, what were you doing when this person was alive? Playing a drama. And that is a tragedy. When the time was so precious, we were just whiling away those precious time playing a drama. When, in case if the truth was told, there was a time to hug and cry. There was a time to say, I love you. There was a time to say goodbye. None of this happens. And all of this happens because the bad news was not communicated. The truth was not told. So these are the 3 points that I want to present in front of you to hopefully convince you that why it is important to communicate bad news. The 3 cardinal points: closure of life's business, a chance to finish off things before you die, preventing hospital hopping and doctor shopping, and also a chance to enhance and strengthen relationships and enhance memory and live life, especially when time is so limited. And once this thing is kind of sinking in to all of you who are listening to it, the problem is not only are we not comfortable talking about these things, we ourselves are not trained, don't have the confidence and the comfort to communicate bad news. There is also another problem: the family members prevents us from talking to the family, from talking to the patient. Oftentimes, when the patient is first brought to me, the patient is made to sit outside, and one or two family members will come in stealthily, and with a lot of anxiety and fear on their face, and they'll come and tell you, doctor, please don't tell this to the patient. So basically, the family member is indulging in collusion, and what that means is they are trying to convince me to enter into a conspiracy of silence. Conspiracy of silence, that is, let us have this discussion, sharing of information between us, but don't tell it to the patient. So that is the conspiracy of silence. And the family members do not have a bad intention. The intention is good because they're just trying to protect their loved one, that is the patient in this case, from harm, because they believe that telling the bad news, telling the truth, will harm the patient. And just like for any of us, we have our own beliefs. Whether it is rational or not, it's a different matter. But for us, our beliefs are very real. And if anybody challenges our beliefs, we become very uncomfortable. We become agitated, we become anxious, we become angry. So if you tell the family members, no, 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 that is all stupid, it is bunkum, there's nothing like that, we should tell the patient and it's the patient's right, etc., etc., then their fear is only going to go up because they're already scared. They're scared that we may accidentally, inadvertently, or with intention tell the bad news to the patient. And now if you're telling them, no, 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 we should tell the patient, then their anxiety is only going to go up. Remember, in palliative care we talk about relieving the suffering of the patient and family. So forget about the patient for the time being. See, the family member in front of you is suffering. The family member is scared, family member is anxious. At the same time, family member is helpless because the family member needs our help to help their loved one. So it's a mixed emotion. So how to manage collusion? Do not increase the anxiety of the family member, decrease the anxiety of the family member by saying, okay, no problem, I will not pay. So basically, you agree to collude. In my usual practice, apart from saying, okay, no problem, I also ask them, so what have you told the patient? And they would say something, let's say they say, I told it's an ulcer, etc. So I tell them, okay, so shall I also say it's an ulcer? So this way, you bring down the anxiety of the family. Because remember, you cannot reach the patient without the permission of the family. In our culture, patient autonomy is subservient to the role of the family, the power of the family over the patient. In our culture, family comes first, individual comes second. So patient is brought to us by the family and not the other way around. Therefore, we have to have the family on our side. And the starting point, the fulcrum of managing collusion is agreeing to collude. Now, once you've agreed to collude, you may bring down their anxiety, but that doesn't mean the family starts trusting you. To earn the trust, you have to listen to the family's concern. You do active listening skills with the family, all the things that we learned last time, right? Build up a relationship of trust. And it takes, sometimes it takes time, sometimes it takes a lot of effort, sometimes it comes effortlessly, sometimes it doesn't take time. But one very simple trick of earning the family's trust is to learn symptomatology well. When you are being taught pain management, focus on the subject, because when you relieve the patient suffering, when the patient smiles because the patient is no longer in pain, is no longer breathless, is no longer having nausea, is no longer having itching, when the patient smiles, there's a glow on the patient's in the face, then the family will automatically start trusting you. It's a very, very powerful tool to earn the family's trust. So, learning symptomatology well and making sure that your patient is comfortable as early as possible, that will earn, that will help you earn the trust of the family. Along with it, practice active listening skills. So it is both. So this way, once the family starts trusting you, then they will start listening to you. When they start listening to you, then you can bring up these topics that we talked about. Basically, then you can reorient the family. It is not easy. It takes a lot of effort. Initially, we'll have a lot of failures, but as you practice, as you get better at it, your conversion rates will improve. However, please be prepared for failures, because despite uh, here I am teaching you all of this, I experience failures. And of course, the failures are less compared to how it used to be when I was in the beginning stage of my career. But still, please remember, you can never be 100% in converting people's mindset. Be prepared for failures. There is no shame in failures. The only shame is in not trying. So, whenever you are facing a situation where the family member comes to you and says, please don't tell the patient, remember, you are dealing with collusion. The standard operating procedure is agree to collude. The second point is earn the trust of the family members so that they now trust you and they listen to you. Then try to reorient them. And once you reorient them, many times the family members tell me, oh, doctor, I can't tell this to the patient. Please help me. Can you tell this? So I said, okay, no problem. I will tell this. I also add, however, if I feel that the patient does not want to listen, I will not force the bad news on that person. I don't use the word patient, but for our class, I am using the word patient. I will usually use the name of the patient or address that person in any other manner which is respectful. So please do not make your agenda that you have to convert the family. You must try to reorient the family and be prepared for failures. And there is no shame in failing, trying and failing. The only shame is in not trying. So once you have the green signal from the family, then you can approach the patient. Meanwhile, you're already treating the patient, providing care for the patient. But once you have the green signal from the family, then you can approach the patient for an elective procedure called communicating bad news. It is usually an elective procedure. Sometimes you may have to do it as an emergency procedure, but by and large, we should train to do this as an elective procedure. The usual standard operating procedure worldwide is called the SPIKES protocol. The SPIKES being an acronym, it means setting up the interview, assessing the patient's perception, obtaining the patient's invitation, giving knowledge and information, addressing the patient's emotions, strategize, and summary. This is basically the acronym. Now the question is, how do we actually do it? For this, let us have a case study. You have a referral letter brought to you by a patient by the name Mr. Bharat, who is 60 years old gentleman, who has been experiencing abdominal discomfort and weight loss for about 2 months duration. He initially went to the local GP and was given some medications, what you call symptomatic medication for about 1 week's time, and subsequently was evaluated with some X-ray and subsequently referred to the gastroenterologist in the city hospital. There he was subjected to further evaluation. A CT abdomen was done, which showed a mass lesion abdomen, and OGD biopsy histopathology showed carcinoma stomach. Exploratory lab done, multiple peritoneal mets were found, and nothing much was done. The abdomen was closed, and this patient has been referred to you for what we call symptomatic or supportive care. Even today, most doctors do not like to use the word referring for palliative care. They usually use the word referring for symptomatic care or supportive care, and you have the patient sitting in front of you. This is basically the referral letter. This is the medical story, and most of you will be familiar with some or the other version of this. So now let us hear from the patient. What does the patient has to tell? So Mr. Bharat, tell me, what brings you here? I've been having gas since about 2 months, and so I went to my local doctor, and he gave me some gas tablets, and I took it for 1 week. There was no relief. So I went back to him, and this time he asked me to get an X-ray of my stomach. And after that, he gave me a letter to see the gastro doctor at the city hospital. So there, the gastro doctor did a scan and a tube test, and after that, he said that I required surgery. I did not have any money at that time, so I went back to my village. I tried to arrange money. I sold off my cow, and finally, when I had enough money, I contacted them. They gave me a date, and then I got admitted, and the surgery was done. After surgery, they gave me this letter to come and see you. So this is the patient story. Now, remember, we just heard what the patient says, but that is not enough. We need to understand what is the patient's insight, or as it is written in the spikes protocol, the point number 2, what is the patient's perception? What does the patient understand about what is going on? So therefore, if you remember our history taking 2.0 that we did last time, when we incorporated active listening skills, so we need to use that method and find more information. So I would do the interview in this way. Hello, Mr. Bharat. Come sit down. Tell me what happened. Tell from the very beginning. Uh, I've been having gas since about 2 months duration. So I went to my local doctor. He gave me some gas tablets. I took it for about 1 week. There was no relief. So I went back to him. Then he asked me to get an X-ray of my stomach, and then he gave me a letter to see the gastro doctor. Wait. Um, what was there in the X-ray? What did your doctor tell you? Um, I don't know the result. He said something, then he said, I'm going to give you a letter, you go and meet the gastro doctor. Okay, fine. Then go on. So I went to see this gastro doctor in the city hospital, and so he said he need to get a scan done and a tube test. 1 second, hold on. I just want to go back. So the doctor, your local doctor, did he tell you why you were being referred to the gastro doctor? Well, he did not specifically say. He just gave me the letter, and I think it is for the rest of for the better treatment. Okay. And then you said that the gastro doctor asked for a scan. So what was there in the scan? What did the doctor tell you? I don't know. He said something and all. I did not understand what that. Okay, fine. And what was the tube test about? Why did they, get that? Do you have any idea what was that for? I don't know what that was for. I don't know what the result was. I mean, they were saying something. They said that I need to undergo a surgery after they did all these tests. Okay, then what happened? I did not have any money at that point of time, so I went back to my village and tried to arrange funds. I sold off my cow, and then once I got all the money, then I contacted them. I got a date, and then I got admitted, and then the surgery was done. And after the surgery, they told me that they will give a letter to come and see you. So, what did they tell you after the surgery? What happened with the surgery? What did they find? Well, after surgery, my gas problem is gone, but I feel tired. Every day, I'm more and more tired. Okay. And did they tell you why you were being referred to see me? They said for better treatment. Okay. So if this way, if you dig for more information, remember I told you last time, the more information we have, the more accurate information we have, the more power we have to come to correct diagnosis and try to figure out what we can do for this person. So if you look at this red in the history, you'll realize this is what is the patient's perception. Many areas, I don't know, I don't know, I don't know. And some areas, it has no much clarity. For example, for better treatment or for surgery, my gas problem is gone, but I'm feeling more tired. So there is no clarity, or sometimes there is totally blank spots where I don't know what is going on. So this patient's insight, this is the way we should be taking history for all patients, whether we are going to do bad communicating bad news or not, because we need to understand what do they understand about their situation. So once we have all this information, then there is this preparation for communicating bad news. Just like any procedure, you have to prepare. So, you know, if you are very familiar with this, great, but otherwise it's always good to go through the medical reports and, and very important, allocate time, because this is an elective procedure. You, ideally you should not be disturbed while you are doing this. So in my case, in case I'm doing this in my OP, I'd prefer to, uh, give time to my patient in the evening time, because OP time would be little quiet. The outside there'll be less noises. I would have finished my day's work. I'll have some time, fixed for that. If I'm doing this in the IP, I'll make sure that I have time to sit in that patient's room and deal with it. So it is basically making sure, just like a surgeon would do a cholecystectomy as an elective procedure, not as an emergency procedure, something similar along those lines. And in my chair, in my room, I usually have some additional chairs. There is always tissue available, there is drinking water available, and all of those things are there as part and parcel of being prepared for the procedure. Of course, practicing active listening skills goes without saying. Now, if we have a patient who is not directly asking us, what is my problem, what is my disease, etc., etc., then you can explore. It is like poking the patient to see whether the patient is interested or not. So for an example, Mr. Bharat, you told me you continue to feel tired after the surgery. Do you wonder why? Do you want to know more about your disease? So this is a kind of exploration you can do if the patient is little shy or little not sure whether to ask, is not a very confident person, not very forthcoming. There are patients who are very forthcoming, but exploration for those patients who are not forthcoming. So when you explore something like that, the patient may say something, yes, I want to know more about my disease. Now, this does not mean that we can straight away start telling this patient that you have so and so disease. No, because we still don't know whether this patient really wants to know if it is something serious. So for that, you have to give a warning shot, a verbal warning shot. Mr. Bharat, if it is something serious, would you still want to know? So basically, there are two parts to it. You are conveying that there could be something serious. And the second part is, in that case, would you still want to know? So this has to be precise. So in whatever language you are going to speak to your patient, the warning shot has to be well formed, and it is good to practice it, how to frame a warning shot, because you don't want to mess it up when you are actually doing it. Because when we do this offline, and when we are doing this for and people are practicing it, many times they find it difficult to frame it and they fumble at that point. So it is good to practice it. In Hindi, I would say, Mr. Bharat, agar baat serious hai to bhi kya fir bhi janna chahenge, or something like that. And if it in Malayalam, I would say, Mr. Bharat, karyam serious aanengilum അറിയണമെന്നുണ്ടോ. So this is basically whatever language you use as part of your medical profession in dealing with your patient and family, practice, because the verbal part of communication should be precise. Can't fumble, can't beat around the bush. Now, why it is important, the warning shot? Because at this point, the whole interview turns from a casual interview to a serious interview. Suddenly, the atmosphere changes. It becomes more serious. Also, the second important part and the main reason for giving a warning shot is it gives a chance for the patient to back out if the patient did not really want to know. Patient says, yeah, I want to know. Mr. Bharat, if it is something serious, do you still want to know? Loss of eye contact, body language means the patient is not sure or does not want to know. Or the patient can verbalize, may give excuse. You give me my medicine, I'll come back after 1 month. Or the patient may divert. You tell it to my children, you tell it to my wife, you tell it to my husband, you tell it to my brother, etc. etc. Or the person may straight away say, I know, I don't want to know. Whichever it is, do not proceed. Most of the time, the important thing is to focus on body language, because body language is the major component of any communication. So loss of eye contact, do not proceed. However, if you have a patient who looks into your eyes and says, yes, I want to know, no confusion. Here is a person who wants to know. Proceed. Only for patients who look into your eyes and says, yes, or non-verbally conveys, yes, then proceed. Now, how do we proceed? You tell a story of the patient to the patient from the beginning. And while you're telling the story, you fill in the blanks. And as you're proceeding with the story, you escalate the information you're giving. At some point of time, the patient may stop making eye contact, because sometimes what happens is the patient has got some new information and needs some time to process this new information, some time to digest this new information. At this point of time, the patient may stop looking at you. So you have to wait. And once the patient again what you call starts making eye contact again, then you can proceed with the story. Sometimes the eye contact may be lost for a long time, and you may be just sitting silently for a long time, feeling little uncomfortable, what to do, what should I do, etc. In that kind of situation, you can break the silence by asking the patient whether the person wants to know more and something like that. When you ask something, then the spell is broken. The patient may again look up or make eye contact, then you can proceed. However, if the patient continues not to make eye contact, that means the patient had enough, at least enough for the time being. That means that storytelling session stops there. Do not proceed with more information. So that is how we understand how much information we have to give. It is very much focused on the body language that the patient is exhibiting. And let us do a bit of a role play over here. So this is after giving the warning shot. Mr. Bharat, if it is something serious, do you still want to know? So Mr. Bharat looks me up in the eye and says, yes, I want to know. So now I'm telling Mr. Bharat's story to Mr. Bharat from the beginning. Mr. Bharat, you have been suffering from gas since about 2 months, right? And initially you went to the local doctor and your local doctor gave some gas medicines which you took for about 1 week, and you said that there was not much relief with that. So you went back to the doctor, and this time the doctor asked you to get an X-ray of the stomach, X-ray, and this X-ray showed something like a shadow. And to know more about the shadow, he referred you to the city hospital. Oh, I didn't know that. Okay. And in the city hospital, your gastro doctor arranged for a CT scan, and the scan showed something like a tumor. And to know what this tumor was, they did the tube test. Now, if you go back, we are filling up the blanks with new information. But with every blank, we are also escalating the information. Remember how we are using the words. Initially, it is something like a shadow. Parchai jaisa kuch dikha. Nedelu pole endo kandu. In the next sentence, something like a shadow graduates into a shadow. Nedelu pole endo kandu. ആ നെഴൽ എന്താണെന്ന് അറിയാൻ വേണ്ടിയാണ് സിറ്റി ഹോസ്പിറ്റലിൽ വിട്ടത്. परछाई जैसा कुछ दिखा. ये परछाई क्या है जानने के लिए आपको सिटी हॉस्पिटल भेजा गया. They found something like a shadow, and to know more about the shadow, he referred you to the city hospital. Now, something like a shadow becomes shadow, and shadow becomes something like a tumor, and something like a tumor becomes a tumor. In the city hospital scan, the scan showed something like a tumor. And to know what this tumor was, they did the tube test. The tube test was done to see if your tumor was something like a cancer or something else. Do you mean to say that I have cancer? I'm sorry. Yes. Mr. Bharat, do you want to know more? They had operated and removed my cancer, didn't they, doctor? I'm sorry. When they opened up your tummy, they found that the cancer had spread all over. They could not remove it. They just had to close it as it was. They lied to me. So now the emotions are coming, the tears are coming. And sometimes it need not be tears, it can be anger. They lied to me, they didn't tell me anything. So whatever it is, whether it is tears or it is anger, both are emotions. And when at this point of time, at certain point of the story, when the patient breaks down or sits in stunned silence, it is very important for you as the doctor to do nothing. I repeat, don't do anything. Just be there. Don't say a thing, don't do anything. At least don't check WhatsApp or Facebook while in this situation. Don't look at your watch, don't look at your file, don't do anything. Just be there 100% for the patient. Let the emotion flow, because that is what is most needed. Don't say any reassuring words, everything will be all right, don't worry, we are there with you, God is testing you. None of this, all of these are just not going to help. The most important thing is your presence. Your presence is the healing. Your presence is what is going to allow this person to ventilate and finish ventilating this emotion. It doesn't take a long time, a minute or two, but it seems like 1 or 2 years for us medical professionals sitting there doing nothing, because all through our medical training we have never been taught to sit still and do nothing. I think the only example which I can correlate with this situation is during surgery, when there is a bleeder and you cannot cauterize it and you cannot tie it. What does the surgeon do? The surgeon takes a pad and presses on that bleeding spot and just waits, does nothing. Nobody in the room does anything. Everybody just stops. They're just not doing anything, not assisting, not doing anything. The surgeon is also not doing anything. They just press on that bleeding area and wait. It is something similar. You just wait. It doesn't take a long time, but it is very important to allow the emotions to flow, because until and unless you don't allow the emotional part of the brain to flow and relax, you cannot have a conversation with this person, because nothing will enter the head as long as the emotions are raised. So you have to allow the emotions to flow. Once you have a patient in this situation, they may ask some questions with a lot of emotions. Be aware that this can be a tricky situation. Do not assume anything. How much time do I have, doctor? So instead of giving statistics about, what are the percentage survival, etc., ask, why do you ask that? And the person will tell you, my daughter's marriage is fixed after 6 months. Should I prepone it? What should I do? So here is a person who asked this question, how much time do I have? Because the person wants to plan something. And we can have the similar question asked by another person, how much time do I have, doctor? And don't assume why this person is asking. Just ask, why did you ask that? Why did God do this to me? So here is a person who needs more ventilation, not more planning. So if you take 10 people in the same situation, they ask the same question, they will have 10 different reasons for asking that same question. You take 100 people, they will have 100 different reasons for asking the same question. So please remember, people are individualistic, they have individual reasons for saying something or asking something. Don't assume, always ask, and they will tell you why they said what they said. And once you understand why they said what they said, you have information, and information is power. So never assume, always go for information. Once all the emotions are taken care of, basically you don't have to do anything. Your presence itself is what will help the flow of emotion and quieten down the person. Once that happens, then you can have discussion on what is possible, what is not possible, what can be done, where can we go, how long will it take, how long it's going to cost, and all the participatory decision making that we talked about in history taking 2.0 can happen here. And always end by giving hope. I talked about hope during my previous conversation. On a regular basis, I have to tell patients and family members sitting in front of me, saying that your disease is incurable, that's why your doctor sent you over here, and I'm here to take care of you. Even if the disease is progressive, I'll make sure that you do not suffer, and you can come back to me whenever you want and any number of times. I will make sure that you do not suffer. So that is an achievable hope I give them. And even if they don't trust me on my word at that point of time, their subsequent experiences with me will convince them that actually it is possible, that even if the disease is not curable, it is actually possible that they don't have to suffer. So this is something that we do on a regular basis, and it is not very difficult. Only thing is that I have the advantage of getting trained by teachers who train me in communication skills, and I practiced, and now I'm in and just passing this forward by teaching this to the next generation. Now, sometimes we may have to fast track communicating bad news in ICU or COVID ward and things like that. Sometimes ER, and sometimes we may not have much time. So therefore, we may not have the luxury of doing it as an elective procedure, and sometimes we have to do it. So therefore, it's very important that you make sure that you are not telling this information to the wrong person. So are you the son of Mr. Bharat, hospital number so and so, who was admitted yesterday evening? Yeah. Yes, doctor. How is he now? Uh, see, despite all the effort, he's deteriorating. I'm afraid he's not going to make it. See, the virus is really going to, overwhelm his system. Basically, don't beat around the bush. Keep it short, simple, and clear. So, but he was not this sick when he was admitted, doctor. He has been rapidly going down. The virus is really hard on him. I'm sorry, despite all the efforts you made for him, he is sinking. Now, this is something that I want you to understand. A lot of really difficult situation can be turned around by using a different strategy. Most of the time, we tell people we did everything possible. We did this, we did that, we did everything possible. Remember, every human being is egocentric. They are not interested in what you did. If you tell we did that, we did this, then the other question is, if you had referred him to a higher center, could he have been saved? If you did not have so much capability, was some other place more capable? Was someone else more capable? So instead of that, my usual practice is I turn it to them. I say, despite all your efforts, you worked so hard, you brought him to all the right places, you worked so hard, you spent so much money, you made so much effort. Despite all your efforts, uh, things don't seem to be looking good. Now, what happens is it suddenly creates a different kind of atmosphere because you are validating them that they did everything possible, and that reduces the tension, that reduces the anger. You're saying that you people did the maximum possible for this person, and this also reduces a lot of intra family politics, because there would be people who are blaming the primary caregiver, bringing, why did you bring him to this place, we had told you to go to the other place, etc., etc. There might be a lot of family politics going on in the background which we are not aware of. The moment you said that you all did the maximum for this person, you all did so much for this, suddenly you are validating them. You're saying that you did the right thing. Therefore, all of this friction between the family, that also quieten downs. Everybody feels good that nobody's blaming them, and also they get validation from the medical professional that there was nothing, no shortcoming, nothing from them. And that is what everybody wants ultimately. that I did not do anything wrong, I did everything possible. So instead of saying that only if you had brought 10 minutes earlier, only if you had, or we did everything, none of these things are okay for cinema, movies, and serials and all. But in real life, it is very important to validate each person's their feeling. We are all egocentric, and therefore, using this word you is very important. You did everything possible, and you practice it, and you will see a dramatic change. Even in emergency, you can turn around things. So what should we do now? Inform everybody in the family, and as soon as the end happens, I will inform you. So remember, no beating around the bush. It is very important. We are very uncomfortable using the word he's dying, he's dead. We are sometimes even uncomfortable using the word cancer, it is progressive, this kind of wording. So it is very important to speak these words. It gives clarity. But of course, when you say it, your body language, your tone of voice, everything should be oozing with empathy, because that is what is very important. Because it is not what you say, it is how you say that matters. We had covered all of that during last time. Also, you can add certain personal touches to this situation, whether you are in the ER or in the ICU. For example, most people, especially in our country, have some or the other kind of belief or faith in something divine. So you can use that as an added incentive or an added personal touch. For example, if it is okay with the family, I would like to say a prayer for him on behalf of all of us. So some personal touches shows that you care, and you are not just a mechanical robot in the guise of a doctor. So that all these things really helps. It protects you. It reduces your stress. Remember, the good communication should work for us. It should reduce our time, energy, effort. It should protect us. It should reduce our stress, and it should get things done. So these are the few tips that I wanted to share with you. When we are doing things in emergency, always give credit to the family members or to the bystanders or people who are with the family, who are with the patient when the patient is sinking or not doing well, and also add some personal touches like these. Now we are. I'm painfully aware that, like last time, we are all still running short of time. So coming to anger, dealing with anger in the clinical environment. Remember, we are not trained like police or the paramilitary or the army to deal with law and order situation. Even if I give you a lathi, you will not know how to break somebody's leg or somebody's head. And even if you knew, you will find it very difficult to break somebody's head with a lathi. Even if you have access to a gun, you wouldn't know how to fire it. And even if you know how to fire it, you will find it very difficult to aim at another human being and fire it. Therefore, please remember, we are medical professionals. We are not trained in law and order maintenance. So if you're seeing a law and order situation, for example, a mob violence, a big crowd of people come to attack you or the institution you're working in, run for your life. Run as fast as your legs can carry you. If you're dealing with another kind of law and order situation, for example, people who under the influence of alcohol or drugs who are getting violent, don't go there, because you are not equipped to deal with law and order situation. You are doctors, you are nurses, you are trained only to deal with the medical profession. And here in the medical profession, in the clinic, we are often exposed to anger by the patient or the patient party. And therefore, that is something that we should all be trained in how to deal with anger. First of all, understand that anger is an emotion, just like sadness is. It is a negative emotion, just like sadness. However, what is different is it is high energy consuming negative emotion. Being angry and staying angry requires a lot of energy. Nobody wakes up in the morning, says, I haven't been angry in a long time. Today I'm going to get angry at somebody. Being angry or getting angry is not at all a pleasant experience. Nobody likes to be angry. It is only situation that leads us to anger. Now, what are the situation? What is the etiology of anger? It is usually multiple. For example, morning you get up, there is no electricity, so water problem. There has been a lot of traffic jam, and therefore your commuting got delayed. And by the time you reached the hospital with your loved one, you're already worried about your loved one not doing well. The person, your loved one, is in pain, suffering. So along with it, you reach hospital. The security person was not very pleasant. They said, no, don't go there, go park there, etc., etc. And you had to park at far off place. So that adds to the stress. Then you went to the token counter. Nobody, making eye contact with you. Nobody smiling at you. You feel totally unwelcome. You finally get a token. You sit there, and then you see that people who came after you, they are getting into the doctor's room, and finally you blow your top. You get angry. You start by questioning the person sitting at the counter, and the person counters back, says something. Then it really, you're already irritated, angry, frustrated. Now you lose it. You totally, burst up like a volcano. Now, this is a common scenario that we often have. If you're in the OP, you can hear angry voices outside your OP. If you're in the ICU, you can hear angry voices outside. If you're in the ER emergency, you can hear angry voices outside. Many a time, remember, healthcare area is not a happy place. People don't come to us because they want to come to us. They come to us because they're sick, they are ill, they are not well, they are in pain, they are suffering. So it's a negative point to start with. Therefore, it is a very, very stressful situation for our patient and family. So all of these things builds up. And therefore, when we see somebody who is angry, we immediately understand that this person is angry. But just for our classroom purpose, let us have a dissection of this anger. Usually, what do you see? If you look at the face of the angry person, the eyes are blazing, the face is contorted into a very angry face, the volume of the voice is very high, the content of the language is very, very unparliamentary, so to speak, not politically correct, at least. And there will be so much adrenaline in this person's body that the person just cannot sit down when he or she is angry. The person will be standing or pacing around because the adrenaline will not allow this person to sit down. So, so the normal anatomy of an anger is, you see usually a male, but females can get also angry. Usually you see a male who is standing or pacing around with angry look on the face, eyes blazing, and a loud voice and very, very unparliamentary language. This is the anatomy of an angry person. Now, remember, the best way to deal with this anger is to allow this anger to flow. But how do you do that? First of all, we have to understand what are the two kinds of fuel that will increase the anger or sustain the anger. The one fuel is ignoring this angry person. That is, you may be scared and you don't make eye contact. You turn your back towards this person. This will make this person more angry and sustain the anger. The other option is that you counter this person. You tell them, you argue with this person. It will increase the anger. You try to explain things to this person. It will increase the anger. Or if the person is very, very angry, if you excuse, or if you give explanation, or even if you apologize, that itself will increase the anger of this person. So any kind of confrontation or any kind of ignoring an angry person will increase the anger or sustain the anger. Therefore, what do? You should neither confront nor ignore. And here, the maximum utilization of body language is required. So let us focus on your body. Remember, an angry person is not the one who is sitting. is either standing or pacing around. And many of the WhatsApp videos where you see that the doctors or nurses getting beaten up, in the beginning stage, the doctor or the nurse is sitting behind a table, sitting, and the angry person is standing. And that is hierarchy. You are showing through your body language that I am superior to you. That increases the anger, right? So immediately stand up, whether you're a nurse at the nursing station, or you're a doctor in the OP, or in the ICU area or ER area, wherever you are, stand up. Because when you stand, you are equalizing eye contact. Eye contact is at level, and that shows equality. That is a very positive body language message you are conveying. And then when you stand, stand with a slight kyphosis, very, very slight kyphosis, because that shows I'm here to listen to you. Remember the body language we talked about last time? When you're sitting, there was one chap who was leaning back in the chair, and there was one lady who was leaning forward. So a slight kyphosis will show, convey the message, I am showing respect. I am here to listen to you. Also show the hands where the angry person can see, because universally hands are the place where you hide a weapon. So if you don't show the hand, the angry person may feel threatened. So all over the world, showing the hand in the form of namaste, or blessing, or salute, all of these are showing hand. It shows that there is no weapon. I come in peace, I come in friendship. So that is the whole purpose of showing hand. So this will be an ideal body posture, body position, and this is how you should start. And let's focus on the face now. Make eye contact. Eye contact shows that you are confident. And why shouldn't you be confident? You're after all in your own space. This is your place. This is where you come every day. So confident. The advantage of appearing confident, even if you're feeling very scared inside, the advantage, you can act confident, but the other person feels that you're confident. And it is very difficult to stay angry or get more angry with a very confident person. But while you're making eye contact, don't smile, because a serious face is required here. Because if you smile, this will be seen as confrontation. Therefore, keep a serious face. Do not smile. This is the only situation where I will say don't smile. Specifically, do not smile, because that will worsen the anger. And also, a serious face shows that you are taking this matter seriously. You are taking this person seriously. That also is very, very positive body language, particularly in this situation. Also, nod your head while this person is using unparliamentary language, because we have to allow ventilation. Remember, in our history taking 2.0, encourage person to talk by making eye contact, nodding your head, and making encouraging sounds. So here you will make eye contact, you will nod head to allow ventilation, but don't smile, don't make encouraging sounds. So just keep quiet, don't utter a word, don't give any argument, don't give any explanation, don't apologize, not a single word. All that you need to do is focus on your body language, because this body language is all about allowing the angry person to ventilate the emotion, because that is the whole purpose of this exercise, to allow the angry person to ventilate the emotion, because the person is suffering. The person is suffering from multiple stress which led to this angry outburst. So before it gets out of hand and he or she damages himself or herself, damages us and the property, it is important to allow this very, very poisonous anger to flow out. Once allowing uh, allowing this ventilation of anger is happening, you will see a change in the person. The loud voice will become moderate voice. It then eventually it become normal voice, normal volume. The bad words will slowly get replaced with normal words. The facial expressions will change. The blazing eyes will calm down. The contours of the face from distorted appearance it will become normal. The person's body language will change. The shoulders will come down. The clenched fist will open up, and that person will appear more relaxed. Once the major anger is brought down, that is, now there is a simmering anger, not a major anger. At that point of time, you can open your mouth for the first time in this session and say, sir, I want to know more about this. Can we sit down somewhere and talk? Now, this is the only time where you invite this person to some, let's go some other place. Before that, never open your mouth and say this, because then that person will feel offended and say, oh, you want me to sit down, is it? And that person will only get more angry. Now, once the major anger has been brought down, it is very important to take this person into a private space, because all this is happening in the public space. And when you see that somebody is very, very angry, everybody in that public space stops and start looking at what is going on. And anger, like most emotions, can be infectious. Remember, all the patients and all the family members who are in the hospital are also sick and suffering. So they can easily get infected by this anger. They can also become angry and they can also join in. And soon it becomes a crowd of angry people. So we don't want that to happen. So immediately, as soon as this person's high anger becomes comes down to simmering anger, then it is important to take this person away from the public space into a private room. The moment this person is taken away from the public space, then the public space becomes normal. People start moving around, walking around, etc., etc., and everything becomes normal. So this is the time where you take this person to a private place, and this time you sit and talk. So when you sit and talk, you sit with a slight kyphosis, keep a hand on the table, or if there is no table, you're sitting face to face on two separate chairs, then keep your hands on your lap somewhere. Don't cross your hands on your chest. Just keep your hands on your lap where the person can see, and maintain contact. Don't smile, nod your head, and allow the person to complete the story. So let the person finish, talk, finish of all the anger, because talking is the way of allowing this anger to dissipate. Sometimes you may, while you're hearing the story, you may realize that there are genuine reasons why this person got angry, and you may have a solution to offer. And if it is something genuine, you can offer an apology as well. However, if there is nothing to apologize about, you don't have to apologize just for the sake of it. A fake apology can trigger more anger. If not overt anger, a covert anger, at least it leaves a bad taste in the person. So, how to end well? Offer a solution if there is a solution. Offer an apology if it is merited. Do not offer an apology if it is not merited. For example, uh, thank you for bringing this to our notice. We are very sorry you had to experience this. Another way of doing that is, thank you for bringing this to our notice. This is what we will do. We'll do this, so that something like this doesn't happen again. Remember, here you are not offering an apology, but in both situations, you are thanking this individual after everything is over, thanking this individual for, you know, whatever information provided. Now, in my day-to-day practice, even just a couple of days ago, I had a similar experience. I mean, this happens very often in, in our life. The point is that we practice this exactly how I described it, and most of our experiences have been that people in the end, they apologize for getting angry and leave. And many times then it usually ends very, very well. They we shake hands, we smile, and we part in a very, very positive manner. And most of the time they end up apologizing for the inconvenience caused. The communicate this in communication skills, the three things that we talked about today, managing anger is the relatively the easier skill to practice. So to conclude, take home points: listen to the family to manage collusion. So when it comes to collusion, listening to the family is the most important point. When it comes to communicating truth, then your role is only a facilitator, as a facilitator of information. That is the only role you have. The patient will decide whether they want to know or not. The patient will decide how much they want to know. Your job is just to facilitate. When it comes to emotion, whether it is crying or anger, ventilation of emotion is a therapy. It is not a waste of time. When you sit there doing nothing, just focusing on the patient, not saying a word, it is not a waste of time. It is therapy. So please understand it. It is therapy, and you, as a medical professional, you are required to provide that therapy. And basically, when it comes to anger management, non-confrontational active ventilation of emotion is an easy skill to master. And with that, I'll stop here. I see that there was uh, uh, some questions, so I'll be happy to take questions.
Thank you, sir. Dr. Priyanka, would you like to unmute yourself? Because your question is, what if he or she is directly abusing us, and if it's not over
Yes,
a
sir.
third person? Yeah, yes, please.
Good evening. Good evening, everyone. Good evening, sir.
Good
Sir,
evening.
actually, like many a times it might happen that the patient's party is already very furious and they have come all bent up and they just come and in the OPD area or wherever they find us and they start abusing the doctor directly. In that case, like it might be difficult because, like you said earlier, that everyone is somehow certain what egocentric. So we being in our own hospital and being abused directly in front of such a large number of patients might not be very like palatable to us as well. So in that case, what do you think we should do, or how should we handle that?
I I always say, more than hard work, it should be smart work. And
Yeah.
smart means we have to be very clear what we are doing. If somebody is abusing us, it is, for example, this incident that happened. Most of my team members were sitting there because we were about to start a meeting, and these two people came and they got very angry and they were using unparliamentary language. The point is whether to take this personally or not is my choice. I would be very stupid to take this personally and start and getting angry and escalate the situation, because it does not serve my purpose. The purpose is I need to resolve this matter. When people are angry, you can't expect them to use parliamentary language, right? They will abuse you, they will do all kind of things, but the point is it is your choice whether you want to swallow it and get angry yourself. If somebody is throwing poison at you, you want to pick it up and swallow. That does not serve any purpose. It will make you sick. It does not solve the problem. So the point is, when somebody gets angry either at you or for what or whatever situation, please remember that your job as a medical professional is to diffuse this angry situation before it escalates out of control. If it escalates out of control, then everybody is a loser. The patient is a loser, the family member is a loser, I am a loser because I may get beaten up or something like that. My institution is a loser, they may break up everything, they may put fire to everything. Compared to that, hearing this abuse here from here and getting it out of here, I granted it may come with a little bit of maturity and wisdom, but we are all capable of maturity and wisdom irrespective of our chronological age. That is what smart is all about, right? So our agenda is to get this situation under control so that we are all safe and everything moves on. Because we have more patients to see, we have more money to make. We don't have time to get involved in stupid things like that. So we just sort it out in 10-15 minutes. Everything is sorted out. We listen, and in about 20 minutes that person apologizes and leaves, and you get on with your life, get on with things to do. Practical, smart. I don't have time to waste. Does that make sense, Dr. Nandini?
Right, sir. Yeah, okay, sir. Thank you. Sir, if you may allow, I would like to ask one more question.
Yes, please.
Sir, actually, like many a times we might get patients who are referred to us for pain management. And when I look at the reports, I might find out that the patient has carcinoma. But when I ask, or sometimes the patient might ask himself that what is wrong? Like, what is the problem? What is the disease? So when I ask what the primary physician told you, they are like, they've just done some battery of tests and they have said that we'll tell you, or sometimes they might not have been told what is going on. So in that case, what should be my stand? Like, what should I tell to the patient party?
Yeah, I guess at this point of time, you don't know whether his family will be willing to give you the green signal to tell the truth to the patient. So you need to buy time, right? So you can tell this patient that I need more information and I'll get back to you, right? So are you telling the truth to the patient, or are you lying to the patient when you say I need more time, I need more information?
No, sir, what I mean to ask is even the patient's attendant is asking me out, like,
Right.
what is going on? That they also don't have any idea of what's going on. In that case, also, like, what should I do?
Correct. Now, if you are practicing in India, I would suggest, it is not a hard and fast rule, but by and large, my practice would be to first talk to the family. Maybe I will, send the patient, okay, I want, if the patient is in pain, I'll arrange for some pain management. I'll say, okay, we'll arrange for IV tramadol, just injection perinorm, injection tramadol and all. And I'll tell them, okay, you go to the daycare and we'll arrange that. Meanwhile, I'll get the family, and without the patient in front of me, I'll ask the family, what exactly do you know? Sometimes the family may know more than the patient, and they may be pretending in front of the patient as if they also don't know. If the family really does not know, then with the family, I will just tell them what exactly the situation is. No beating around the bush. You just convey. See, the report says that this your son, your brother, your father, your mother, your sister, your wife has so and so disease, and as per reports, it seems to be incurable. It is spread all over. So that is why your treating doctors have said there's nothing more to be done from their side. They have sent you to me to make sure that he or she does not suffer. That part I will take care of. So no matter what, I'll ensure that he or she does not suffer. Right. So this much you clarify. It will take 5 minutes to convey that. Then the question is, since this thing is there, so how about what do you think about conveying this to him or her? So you ask their opinion. What do they think? And sometimes they may not have. They may just too stunned. They may not be in a position to say. But you need to work on it over a period of time, and then this gets sorted out. Managing pollution is one of the hardest things to do. The second, comparatively easier, is communicating bad news, telling the truth, and comparatively easier is managing anger. Managing, once you get the once you get the trick of the trade, managing anger happens like this. It's no effort. It doesn't take much time. But
thank you so much.
Yeah.
Thank you.
All right.
Hello, sir.
Yes, please.
So don't we need to talk to the primary physician first before disclosing?
Well, if you have access to, if you have a contact number, by all means, you can ask. In my personal practice inside the hospital, whenever I am going to see a new consultation, for example, if the oncologist has referred a patient in the IP, so I go there, I just study the case sheet. Then before actually going into the patient's room, I would call this oncologist and ask, what exactly is the situation? What are your plans? What have you told the family? What have you told the patient? So I'll get some kind of idea from the treating doctor. If I meet them on the way, or if the OP is on the way, I'll just drop in, poke my head in and say, I'm going to see your patient. This is, I just have a few questions, etc., etc. It doesn't take much. There we can use the Greek and Latin medical jargon and get information very fast. But it's always a good thing if you have access to the primary treating doctor who has referred the patient to you. Do talk to him or her and sort out whatever doubts you have before meeting the patient and family.
Thank you, sir.
All for it.
So we have one more question. One
Yes,
thing
please.
which is even more difficult many a times is when you want to break the news of a serious illness in the case of pediatrics or in an adolescent age group. Even it becomes a little more complicated because even to the parent, you're not sure how you should approach them. So how do we go about this situation as far as communication is concerned?
Yeah, when it comes to children, depending on their age, we can convey the truth. Depending on the age appropriate information we can give, and it's a whole different subject altogether. By and large, we treat adolescents as adults because 13 and above, they start thinking like adults. So especially those who are dealing with serious illness, serious suffering, we deal with them as adult. We take them just like we will deal with adults. However, those who are younger, if we have the permission of the family, we just try to explore about them, and depending on their ability to understand their situation, many times they guide us in having this conversation. They ask us very probing questions, and the thing is that especially when we are dealing with very sick, terminally ill children, the most important thing is to treat them with respect, treat them with honesty. So you may not have to give them in-depth information about the disease, but you can use words like the disease does not seem to be getting better, right? And it seems that you are getting weaker. And then if they ask, sorry, 1 second. Okay. And if they ask, so will this get better? You can say, probably not. Will I be able to go and play? Then you can say, I mean, the best thing is you can use your energy as much as you can and do that. But if you are not having the energy, then you may not be able to do it. So it is basically depending on the child, the age group, the individual child, and how that child wants to interact, the age group of that child, and based on that, their ability to understand the world around them, the ability to make sense of what is happening. I just, just a couple of days, I had this interaction with the 7-year-old girl who had a big glioblastoma, from a foreign patient who had this big mass on the face. And this child, was very, very quiet, very scared. And with some interaction, this child started interacting with me, smiling with me, and that kind of thing. And the child was asked, just asked whether I will be as beautiful as mummy. Mummy was sitting there, and she was asking whether I'll be beautiful as mummy. And so I asked, why do you say so? And she said, this is there, this mass is there. And so then I asked her, what do you think? Then she did not say anything, right? So she did not say anything. She just kept quiet. The whole room was very silent. The mother was also very silent, waiting for what will my daughter say. I was just waiting for what will the daughter say. And she was the very intelligent one. She just kept silent. And that silence was meaningful. It conveyed something. And then I told her, no matter what, you're the most beautiful person here. And there is always something you end with positivity in the end, right? So many times it is need not be words. It can be silence which conveys a message, and not necessarily silence from our end, silence from their end. It's a you just have to go with the flow at a certain moment. So yes, communicating bad news with children is possible, right? Only thing is that we feel uncomfortable because one, nobody's teaching us this. Secondly, nobody's mentoring us with this. And thirdly, we are not in an ecosystem where these things are normally done. That is why the hesitation.
Thank you so much, sir, for that. Again, and borrowing a word from the comment section, exemplary presentation. Once again, we couldn't have the case presentation today for the best interest of interaction with you. We thought we'll have postponed the case as well. But I'm sure that there are a lot of takeaway messages from this, even though many of us are practicing and many of the participants have been practicing since years or decades. There is still some takeaway for them as well. Any closing remarks from your end, sir?
What can I say? I mean, now I'm speechless. So yeah, our session ends, but our relationship does not. I'm available to each one of you in case you find difficulties. Feel free to WhatsApp me, send a voice message or send a text message or send anything. Some of the people do stay in touch, and I'm not a master of everything, but whatever way I can help or contribute in 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 this journey of yours, I'll be happy to be part of it. So I mean, my number is there with Palim India. Feel free to share my number with all the delegates, and that number itself is my WhatsApp number. So yeah, that as I said, the door is never closed. Leaving the door open to all of you.
Thank you so much, sir. And once again, thank you so much for taking out time from your schedule. We are beyond happy to have you for any of our sessions. We'll stay in touch as well, sir. Thank you so much once again. Over to you, Shri. Yeah.
Thank you, Dr. Biju Raghavan, as always. Yes, one thing I can assure from my end is that you always get responses whenever you try to connect with him. He's one of those very few faculties who respond in time as well. That is our personal experience with him. And I believe that you all already have his number. It is in the faculty PPT, which we have already uploaded in the IACO. In case someone is finding difficulty to trace it, do let us know. We will share his contact details. So, thank you, sir, once again.
Lost your voice. Lost your voice. Can't hear.
Yes, sir. There is a slight technical glitch. I hope I'm audible, even though not clear. No. Okay.
Now you.
I was just signing off. So thank you everyone for joining us. We will continue this journey together with another interesting topic and another eminent faculty in coming days. Till then, everyone, take care, stay safe, be happy. Bye bye.